Welcome to Module 1. I'm Dr. Shindo. I'm a neurologist from Japan, and I'm involved in clinical care and research of Alzheimer's disease and amyloid-related imaging abnormalities. In this module, we'll focus on ARIA, which are increasingly encouraged in emergency settings as anti-amyloid therapies become more widely used.
I'm Dr. Katie Buck. I'm an emergency physician at The Ohio State University in Columbus, Ohio, in the United States.
Early detection of symptomatic Alzheimer's disease is essential to ensure optimal outcomes. In stroke care, we often say time is brain, and this concept also applies to Alzheimer's disease. ARIA identification allows for more appropriate and effective treatment decisions. However, emergency clinicians should be aware that administration of TPA can pose potential risk in patients receiving ATTs. Stroke neurologists and emergency physicians need to recognize this important safety consideration.
When these patients are coming to my emergency department or it's on my differential diagnosis, there's a few things I want to think about very quickly. One, how am I going to determine reliably if they're on this medication? And two, if they are, who do I need to get on board to make sure that we're making timely, appropriate decisions for these patients? This can be things like, are they eligible or not for things like TPA and stroke, but also other diagnoses that we make throughout the emergency department visit. For example, if they're found to have a pulmonary embolism, are they eligible for anticoagulation? If not, what are our other options?
ARIA includes two major entities. ARIA E means edema, which is characterized by edema, and ARIA H means hemorrhages, which is characterized by hemorrhage. Both occur setting immunotherapies targeting amyloid beta. The underlying mechanism involves amyloid deposition within several vessels. When amyloid is removed, vascular integrity may be compromised, leading to leakage of fluid or blood into surrounding tissues. So common symptom is some headaches or disturbance of consciousness, visual changes, dizziness, nausea, and gait difficulty. But sometimes severe presentations can include seizures, status epileptics, focal neurologic deficits, malignant hypertension, and intracerebral hemorrhages, some of which can be fatal. ARIA E mimics should be considered first. Importantly, ARIA E does not always show DWI, diffusion restriction on DWI, and approximately half of ARIA E lesions may be DWI negative. When DWI hyperintensity is present in ARIA E, the ADC map typically shows increased signal consistent with T2 shine through rather than true diffusion restriction. In contrast, ischemic stroke is characterized by reduced ADC values reflecting cytokines edema. On MRIs, incomplete CFS may be observed particularly on conventional FLAIR imaging. 3D FLAIR using non-selective inversion pulse provides CSF suppression and therefore represents preferred sequences for assessing ARIA E in clinical practice. Similar MRI findings also seen in other conditions, including posterior irreversible encephalopathy syndrome, evolving subacute ischemia, and inflammatory cerebral amyloid angiopathy, CAA-related inflammations. For this reason, awareness of amyloid targeting therapy is critical when interpreting these imaging findings. ARIA 8 mimics should be carefully evaluated. Susceptibility appears as hypointensity, forcing near regions expected magnetic susceptibility. In addition, artifacts in phase and contraction detection, particularly in the region the trochlear may mimic cortical siderosis or microhemorrhages.
Thankfully, MRIs are increasingly available all over the world. And whilst it might be tempting to try and substitute perhaps CT for MRI, because CT may pick up the more obvious ARIA lesions, such as significant edema or macrohemorrhages, CT is not sensitive enough to pick up mild ARIA and definitely cannot pick up microhemorrhages. And these would be the warning signs for further problems. So I think that in general, the advice is if you don't have MRI, you're not ready to give anti-amyloid medication safely.
In my experience, because we actually did not really meet the area mimics, such as the posterior reversal encephalopathy syndrome or cerebral amyloid angiopathy related inflammations. But I think we can differentiate them based on the MRI finding and also the clinical course and also the image like location or stability. We have to consider the other situation, especially ischemic stroke.
We have to bear in mind that these mimics are really not very common. And that the most important thing is to remember that ARIA is possible in patients who are being treated with anti-amyloid therapy. And that this is an important differential if you come across symptomatic patients and who have these kind of MRI findings. And as has been emphasized, the most important differential would be stroke.
When I think about ARIA mimics, I think about how understanding them affects my differential diagnosis. As you know from working in an emergency department, if you don't think of it, you can't treat it. And that's where this becomes critical. When a patient presents with the abnormal neurologic symptoms, for instance, you need to make sure you think of ARIA so that you don't accidentally treat them for an ischemic stroke when the TPA or TNK could actually harm them.
In practice, differentiating ARIA from other neurotic processes depends heavily on treatment history, symptom evaluation, and distribution of imaging abnormalities. Anti-amyloid monoclonal antibody exposure is often the most important contextual clue.
I don't know. I've never really seen a case of CARI.
Yeah.
But it's a clinical syndrome because you need to have really bad hypertension, right?
I think we have to consider the area first, and we can exclude the CARI and the press by the image and history taking. And also, like Dr. Chen said, breast patients usually have a fluctuation of blood pressure or show the very high blood pressure. It's some clue we can to differentiate them. The CARI and the press, the pathophysiology show actually related to the vasogenic edema. However, the ischemic stroke is due to the mainly the cytotoxic edema. So maybe we can based on the MRI image to differentiate them. But I think it's important to consider these area mimics if we meet patients in emergency department.
My opinion is that neurologists tend to love very rare exotic conditions, but the practical implications for these differential diagnoses remains that we should stop the anti-amyloid therapy and think about what to do next, which would be monitoring and repeating the MRI. In terms of press, managing the blood pressure is probably appropriate and would be done anyway.
Often when I'm trying to differentiate ARIA from other neurologic pathologies, I can't actually do it in the emergency department. Often that's because in my practice and a lot of practice in the United States, the MRI does not happen instantly, and it can take hours or even days depending on the patient and the clinical flow. Therefore, sometimes the best thing I can do for the patient's care is to get a really good history from the patient or the family or with the pharmacists I have next to me to know whether or not they're on this medication and include it in the initial differential diagnosis, so that when we get further into the hospitalization and they have that imaging, they can differentiate it from these diagnoses listed here. Thank you for joining us for Module 1. Don't forget to join us for Module 2, Imaging Patterns of ARIA, MRI versus CT in Emergency Care.